Experience-based design has been used in lots of different settings, so it's and often used at a project level really. So it's been used in cancer care, end-of-life care, community settings, so for example with multiple sclerosis, mental health services, learning disabilities. So it's been used in lots of different settings and in lots of organisations, so across the NHS and wider. So we know it's used in Scotland, Wales. It's also used in other countries in Europe and spread as far as Australia, Canada, the US and New Zealand. As I started, I said about it being project-based, and I think in terms of the long way to go, it's actually about that spread across organisation or across whole health systems. So, so there's lots of people using it, but it's actually about how it becomes embedded. They use it in individual projects quite often, or a team might use it because they've used it once and they use it then for all of their improvement work, but actually it becoming wider spread across an organisation or wider spread across a whole system, that's where we need to be getting to with it. Experience-based design is really about truly understanding experiences. So it's about understanding patient experiences, families' experiences, and the staff delivering the care. And using co-design, so working together to understand what currently happens, identify where there may be opportunities for improvement by understanding what happens at each point. And we use the word touch points, but that's actually about where we get heightened emotion, where there's interaction with the service, which are not always our normal process points. So if you're using other quality improvement methodologies, so you might use a process map, and you will have things such as arriving at reception, for example. But actually the touch points before that might be some of the signage on getting there and all of those aspects. So experience-based design, it looks at things much more widely than some of the traditional process improvement type work. And the real thing is it's about designing better services for patients, staff and for families.
The first work in the UK that using experience-based design was done in Luton and Dunstable, which is a hospital, a general hospital with patients with head and neck cancer, and it was because of the write-up of that process actually and the results of it and the demonstration of how effective it was that we took it up on the point of care programme. So in Luton and Dunstable, the head and neck cancer service was already one of the best services in the hospital. It was doing well on all the measures of performance that they had, and so they thought it would be a good place to start. But having gone through the process, they made, in fact, 42 separate changes to the service to improve it from an experiential point of view for the patients. When we then took the methodology and tested it in South London in 2 teaching hospitals with patients with breast and lung cancer, I don't know what it is about the number 40. It may just be coincidence, but again, in those services, around 40 improvements were made, and these are everything from small changes that can be done very quickly by frontline staff, simply, for example, rearranging the way a waiting room was organised, through to much more systemic type changes, which would involve changing the ways in which, for example, the orientation of new members of staff was done, or customer care training for some of the frontline receptionists.
And so an example about transitions, interfaces of care, I think really was, we did some work with an organisation, a commissioning organisation, about services for patients with multiple sclerosis. There was a lot of pressure on this organisation from the voluntary sector about employing a specialist nurse. And the commissioning organisation were a bit concerned about just having a specialist nurse to add in to the current service without knowing what was really happening. So we worked with the commissioners, with the acute trust, the community service providers, the social care providers and the voluntary sector, and really understood the patient journey. So for patients who have MS from diagnosis right through to the current day, and for some people that was many years journey. And it was very much about their interactions with healthcare, their interactions with social care and the voluntary sector. And we learned a lot about how people were accessing services and how there were very different ways of accessing services, and people utilised those in many different ways. And I think, you know, and one of the big things that we learned from that was it was about designing a coordinated service. So the big thing with people's stories were that they kept falling between services, so they didn't know where to go. Some people were missing out on services. If they were referred, so if they wanted to have therapy services, they would refer to the GP, and then the doctor would refer them to, for example, to the general physiotherapist, and then they would then get referred to the specialist physiotherapist, and all of these additional steps, which would just take time, very frustrating for the patients not being able to access the services in a timely way. And actually, and as a result of that, what was designed and developed and commissioned was a service that was about coordinating access to community services. So there was self-referral into therapy services, for example. They developed a gym service for the low-level multiple sclerosis patients, so that they could access those in the physiotherapy gym. So they weren't having, you know, active treatment, but they were able to access the gym services to be able to utilise them to maintain levels of fitness. And that was quite different from what had been expected at the start. So the expectation at the start was we'll just have an MS nurse, and we'll maybe have some more community neurology clinics. But in reality, what really needed to happen was the coordination of the services. So they designed a very different service as a result.
I think what we would say from our experience is that it does matter, and that, in fact, both parts of the organisation have to be connected to the process. So frontline staff can do experience-based design on their own, but it won't go as far and it won't go as fast. They really need the attention of the executive to the process and to what the kind of issues that it's raising, particularly when it means that, for example, the story of a patient is not confined to one service only, but will almost inevitably touch on other parts of an organisation or other parts of the system. And the people who have the perspective from which to see all of that are the more senior people. And so there has to be a really good communication between the two. I think in our experience, the initiative can come from any of these levels, though, to start with. So often it's somebody at frontline level who hears of the process and thinks, I'd really like to do that in my service. But as I say, they won't get very far without an executive sponsor and without the board level taking an interest. And equally, the executive team won't go very far if they can't fire people up at the front line to do the work in a real way.
Yeah, and I would just add really is that, you know, the one thing that the exec team, exec sponsor can do is really about removing barriers. So, you know, some of the challenges, as Jocelyn mentioned, between services, actually, and also getting them to talk to each other as well. Sometimes that can be, so that's really important. You have to have champion at bottom level as well. So at the front line, you have to have someone who has passion. So actually, you need both. And then the other element really is the middle manager. So because quite often that's where the barriers can become, because it can be seen to be, is it going to take time out of you delivering care? And so it's actually about ensuring there's that empowerment at the middle level as well. So the bottom up and the top down are important, but actually has to happen at all levels.
We've had variable success at that. We haven't approached doctors in any way. I assume you mean doctors. So we haven't set out to treat them differently in any way. It's more that what we observe is that teams that have a doctor who's committed to the work, who gives it his blessing or her blessing, as it were, and who takes an interest in it, somehow have a level of energy and inspiration and engagement which is different from those that don't. We have worked with teams where the doctors haven't taken an interest, or haven't made, by which I mean making the time to get involved, and that's always inevitably only a partial result, because the doctors play a very important part in the lives of patients, and they equally play a very important part in the life of the system as a whole. But I would emphasise that where doctors have got engaged, we have seen wonderful results. And there's something about the engagement of senior doctors which other staff find very kind of satisfying and inspirational to work with. So I think it is very important to try and achieve it. And the way in which doctors are likely to get involved and take it seriously is if other doctors do so.
One way that we've found actually that works really well is actually using patient stories. Because doctors relate really well to patient stories. Yeah. They relate really well because, you know, no healthcare professional comes into healthcare to provide a bad experience for patients. And I think, and that's probably for all the champions, but I think that, you know, if they hear a story, they imagine that because their interaction is okay, they don't really always recognise what's happening outside of that. And I think when you hear patient stories about, you know, where people's waiting area, people not being told that why the clinic's running late. You know, often doctors, if they're running a clinic, don't know that their patients haven't been told that they're having to wait. So I think it's, you know, the patient stories actually can be really helpful in helping to recruit those champions.
There is some research already that tells us that the experience of patients and the clinical outcomes for patients are associated. There's also some evidence that positive patient experiences are associated with more safe care. So decreased mortality, reduced rates of surgical complications, for example, lower rates of hospital-acquired infections. There is some evidence about experience and outcome of various kinds. It's not a huge body of evidence. It's often very particular to one service. So it's in intensive care or it's in surgical care. But I think that what we're seeing is research institutes getting more interested in the question now. And so my expectation is that there will be more scientific research trying to understand these associations and to see how they're causally related, whether or not they are causally related. I think there's a long way to go. And if you take the example that Helen was talking about earlier of transitions in care, for example, and the whole idea of coordination and integration of care, which is a very important aspect of healthcare delivery, particularly for people with long-term and chronic conditions, what you see is there's been almost no evaluation from the patient's point of view of changes that were designed to achieve better integration and coordination of care. We've been looking to see what measures there are of continuity from the patient's perspective, and what we find is that there isn't much work in that area yet. So I think there probably is a very long way to go still to evaluate service changes from the point of view of the people who are on the receiving end. We're very good at evaluating service change in terms of efficiency, productivity, sometimes clinical quality, sometimes safety. Much less good so far at linking patients' experience data into that.
I think, usually when we have any sort of economic crisis, then we tend to move towards sort of focusing on productivity and efficiency, and the NHS is no different, and and that's an area we're having to make these massive savings, and that is where organisations are looking. So potentially it might mean that patient experience isn't at the forefront. One advantage we do have is that the dimensions of quality within the NHS are very much so they're about clinical effectiveness, they're about safety, but patient experience is given equal footing within that. So there's, the driver is there for it still to maintain, but actually with financial and performance management, there is always that risk that patient experience will go down the shopping list.
Some of the things that are often seen as soft targets for making savings are things like training and education, and certainly investment in new initiatives. So all of that, I think, puts this a bit at risk. This goes back to the question about research, actually, which is, were we to be able to demonstrate with hard data the relationship between patient-centred care and cost, I think it would be, I'd feel we were on safer ground, but that research hasn't yet been done. I would say that we have learned a tremendous amount from spending a few days in Ontario. Particularly, I think things that you've taught us about are the value of the patient and family advisory councils. We've really seen a wonderful example of that. And we've also heard about a really thoroughgoing involvement of patients in working in cancer services, which is very impressive. And at the experience-based design training, what we saw there was, I would say about a third of the people in the room were probably patients. And I think that really made a difference to the training. So that all of those we take home. I think that if there's lessons that we've learned that we could share with you, they're about the importance of leaders at every level of the system, taking the experience of patients to heart and taking it seriously as a goal for the service. And that's professional health professions and the management equally. So at team level, organisational level, and in the wider system, you really need alignment of what leaders are saying and doing and the decisions that are being made to drive this.
I think, yes, keep going with what's happening. It was great having the patients and families in the room yesterday. That worked really well. And as I say, in our organisations, we've only had a few patients and families in the room. So that was fantastic. I think, in terms of pitfalls, I think it's about ensuring that you break down some of those barriers. So one of the things that we often find is that things like clinical governance can get in the way. So do you need ethical approval? Well, experience-based design is a service improvement methodology. It's an approach to service improvement, so you shouldn't need ethics approval. And we've found, even though we've gone through our national body, our research body, to get a letter which says you don't need to have ethics approval, there are still some organisations who are constrained by their governance and research committees who will say, oh, but we still can't do it, you still have to go through ethics clearance. So I think in terms of at a regional level, having somebody or some organisation who can help take down some of those barriers and enable the work to happen for those leaders at all those levels, I think that would be really valuable.
My sense, I come from the King's Fund, which is very involved in integrated care in England at all levels, policy, research, practice. And what I know of the PATH project is that it's very much there alongside others in the world trying to tackle a really difficult problem. The King's Fund has connections to people in Singapore, for example, who are doing similar sorts of work. certainly in the UK and in USA. So I think the Change Foundation is really doing something very, very important, and I think there will be people outside of Ontario who want to know what the lessons are from the work that you're doing here, and to learn from the solutions that you find.